In this video, we're going to talk about acid-base balancing. And what exactly is it? Well, it's basically our body's balance between the acidicness versus the alkaline uh, content of our blood. It is very tightly controlled because even just small deviations from the normal range can actually end up affecting many of our organs. And so we do need to make sure we're keeping this within the range of desire. And the way that we do that and the way that we control that is through our lungs, through our kidneys, and through our chemical buffer systems. So, when we look at our pH scale, which is our measure of acidicness versus alkalinity, we are looking from 0 to 14. And the way that I like to think about this, because one of my favorite movies is Aliens, the second one. And when you think about the alien blood and how it is just pure acid that can drip through all of the metal in the spaceships, we're looking at around, a 0 for that. So I always remember aliens, our blood is going towards 0 versus more of my like sodium. My like baking soda and such is now moving more towards that 14. So, what is our normal pH of blood itself? Well, we're looking at a 7.35 to 7.45 range that we need to keep it in. As soon as we start going more acidic and having that pH drop lower than 7.35 or more alkalotic and having that pH higher than the 7.45, that's when our bodies will start to compensate in order to make sure that it returns it back to this range so that we can keep the body in good health. So, a question for you: symptoms of a low plasma pH may include what? So, I want you to look over the questions, pause the video for you to think about it, and give an answer. Good. So we are looking for D, right? So that's A and B combined, which means symptoms of a low plasma pH include things like the central nervous system depression and confusion and disorientation. So, why do we care about acid base balancing? Well, the function of our proteins, like enzymes and membrane channels, are all sensitive to these small changes that we might see in our pH, right? So, things that are acidotic was a pH less than 7.35. The pH is simply too low, and our neurons become less excitable, and we end up having central nervous system depression. We also will experience things like confusion, disorientation, coma, death from the depression of the respiratory centers may also come. If we are leaning higher of a pH above 7.45 and we're moving more towards being too alkalotic, that pH is too high and our neurons actually become hyperexcitable. So we get things like numbness and tingling or muscle twitches. So we have a lot of inputs into our body, right? So acid inputs that are contributing to our pH we can get from amino acids within the diet, from fatty acids within our diet, through anaerobic metabolism, abnormal fat and amino acids that are present in the system. Metabolism during diabetes can happen. And then we have a huge input in any time that our cells are moving or functioning with that production of carbon dioxide. However, our base inputs are really minimal. Some bicarbonate can get in. And if you happen to be like taking Tums, you can take that in as well. But the reality is, we have a lot of acid that we need to dispose of to compensate for this extreme intake of acids without having it balanced with any base intake. So, another question for you to contemplate: the most important factor affecting pH of the plasma is the concentration of what? So, take a look. It's kind of a short term memory recall. Pause the video if you need. Good. We were looking at carbon dioxide. Really, that is coming because of our metabolism at the cellular level. So it all comes down to our wonderful equation that we have here, in which we have carbon dioxide, and whenever it comes in contact with water, it is going to go through a process in which we are creating carbonic acid, in which then it is acted on by carbonic anhydrase in order to divide it into bicarbonate and hydrogen ions. So we can see this result of how carbon dioxide that's being released can transform into hydrogen ions, which is a lot of where our acidicness is coming from. Now, this equation goes both ways. So we can go from the carbon dioxide to the hydrogen ions in the bicarb, or it reverses in the opposite direction, in which whenever we have hydrogen ions in the system and there's bicarb available, it will turn into carbonic acid, which is very unstable, and then will break apart into carbon dioxide and water. And this is how we can actually transfer and move these different chemicals around in our body, and how we can get carbon dioxide that's being produced at that cellular level out into our breathing to be able to exhale. So, what I want you to do is, on a scratch piece of paper, what are the three primary systems that regulate against changes in our blood pH? So, we have three different systems that we have. Which one of them are responding quickly, or which ones are more slow to respond? So, take a moment, pause the video, and I want you to brainstorm before continuing on. Good. So our short term is really looking at our ability to buffer acidicness. So we look at the extracellular buffers like bicarbonate. That's our major one. Phosphate also contributes minorly to our buffers, but really a lot of it comes from that bicarbonate. We also have some intracellular buffers like organic phosphates, such as like ATP, and proteins such as hemoglobin. But really, when it comes down to it, especially for our extracellular buffers, we have that bicarbonate available to be able to buffer. Now, a midterm solution is conducted by our lungs, in which we're just trying to blow off some of that carbon dioxide. So we will dump that carbon dioxide into the atmosphere. It does happen pretty quickly. And really, this accounts to be able to buffer about 75% of our pH disturbances. So it is very effective at being able to buffer off that excess acidicness to convert it through that carbonic anhydrase equation to push it back towards carbon dioxide to be able to blow it off through respiration. Then our long-term solution is the kidneys. I want you to remember that the kidneys really are the number one homeostatic organ that we have. So we can buffer things off through excretion of these hydrogen ions, and also through the production and recycling of bicarbonate. So let's do a little short term recall for a moment. Take out that scratch piece of paper again, and I want you to write down that bicarbonate equation. Can you remember what we just went over as far as that transfer, the carbonic anhydrase equation? Good. So if you remember correctly, we are looking at whenever carbon dioxide is available in the system and there's water around, it will turn into our carbonic acid, which is a very unstable molecule, which will then, through carbonic anhydrase, break apart into our bicarbonate and hydrogen ions. So we have this chemical buffer system, and we are trying to resist these changes in pH whenever there's a strong acid or base that is required or is added to the system. In our bicarbonate buffer system, we get a mixture of our carbonic acid, which is a pretty weak acid, and salts of the bicarbonate. And then we can use it to be able to buffer intracellularly and extracellularly. And really, looking at this bicarbonate buffering system that we have right here, it really is the only important extracellular uh, buffering system that we have. So, taking a look at our physiological buffering systems, we've got the respiratory system and the renal system, and they act more slowly than this chemical buffer system that we just talked about. They have more capacity than the chemical buffering systems in order to actually help us to balance out our pH. So, we're going to take a look respiratory acidosis and alkalosis. So, it's an important indicator of how our respiratory function is going by looking at our partial pressures of carbon dioxide. Normally, we want these pressures to be between 35 and 45 millimeters of mercury. If our partial pressure of carbon dioxide ends up being reading greater than 45 millimeters of mercury, it often indicates that we are in respiratory acidosis. It is the most common cause of our acid base imbalances, and it's usually because we're having difficulties breathing. So we get a decrease in the ventilation, or for some reason, the gas exchange is not happening as effectively. So there may be fluid that is built up within the lungs, and it's making it for that gas exchange to be compromised. And we will see this by having a drop in our pH and then a rise in our partial pressure of our carbon dioxide. So looking at our end tidal CO2 numbers. With our partial pressures of carbon dioxide that are below 35 millimeters of mercury, that usually indicates respiratory alkalosis. And it's a common result when we start going into hyperventilation. So, if you remember hyperventilation syndrome, or just by reacting to stress in the situation, or going into shock in response to pain, any of those things can cause us to hyperventilate, and it can actually start to decrease that end tidal CO2, ultimately then increasing our pH. With our metabolic acidosis and alkalosis, really it's like any pH imbalance that we have that's not caused by abnormal CO2 levels in the blood. So if it's not happening through the respiratory system, we're going to classify it as metabolic. And it is also indicated by having abnormal bicarbonate levels. So that's what we'll be able to read if we were to have blood drawn to be able to note what those bicarbonate levels are. So, what are our causes of metabolic acidosis? Things like ingesting too much alcohol. Alcohol is converted into acetic acid, in which then we have a lot of acid building up within the system. So that would be that would be a good example of metabolic acidosis. We also have excessive loss of bicarbonate. So if we are persistently having diarrhea and getting rid of bicarbonate, you will also see metabolic acidosis. Accumulation of lactic acid, such as what we might see from like a rhabdomyolysis. You could also see it when we're going into shock, or if there's ketosis that's happening in a diabetic crisis. Also, starvation, or if there's kidney failure. Those are all examples when the acid starts to build up within the system, and it can lead to metabolic acidosis. Metabolic alkalosis is a lot less common than acidosis, and it's usually indicated by rising pH and also bicarbonate levels. This one is usually caused by vomiting of the acid contents of the stomach, or by taking an excess of a base. Like if you were taking Tums or other antacids, it could increase that bicarbonate level as well. So, looking at vomiting and excess intake of Tums or other antacids could be that key indicator that we are suffering from metabolic alkalosis. If an acid base balance is coming to fruition and it starts to malfunction, and it's because of one of the buffering systems starts to fail, the other one will start to compensate. So the respiratory system is going to attempt to correct anything that is going wrong with the metabolic side of the acid base imbalances. And then the kidneys will try to attempt to correct any respiratory acid base imbalances. So, if something's going wrong with the respiratory system, the kidneys will try to compensate. And anything that's going wrong metabolically within the body, the respiratory system tries to compensate. So during metabolic acidosis, we have high levels of hydrogen ions that are stimulating our respiratory center, right? If we go back to the reasons on why we breathe, it's because we have an increase in hydrogen ions at the level of the medulla oblongata. When it's sensing that we have these high levels, it is our stimulus to be able to breathe. So we will start to breathe more quickly and with larger depth in order to try and offload those hydrogen ions. Well, the blood pH is below, because we have so many hydrogen ions, it's below that pH of 7.35. And you'll also see the bicarbonate levels are low. As our carbon dioxide is eliminated by the respiratory system, so we're breathing that out. Remember, we have that conversion through the bicarbonate equation of moving from hydrogen ions and binding with bicarbonate in the system that is there. And then it transfers into carbonic acid and then splits off into water and carbon dioxide. That carbon dioxide is now able to be exhaled or expired through the respiratory system, and now our partial pressures of CO2 will start to fall below normal also, because we are breathing off so much. Here's just our equation again to show that in action. So, respiratory compensation that we have for metabolic alkalosis is that we will actually have slow and shallow breathing, allowing for that carbon dioxide to accumulate in the blood more. And going through that carbonic anhydrase or bicarbonate equation, it will move from that carbon dioxide ultimately into those hydrogen ions. But what we'll also see is that we have a high pH over 7.45, and the bicarbonate levels are also high. So, renal compensation, if we're experiencing respiratory acidosis, because of hypoventilation, uh, and it's causing this elevated level of carbon dioxide, the renal compensation will be indicated, and it will increase our bicarbonate levels to try and compensate for that extra buildup of carbon dioxide. If we're experiencing respiratory alkalosis, with that low partial pressure of oxygen and a high pH, that renal compensation is going to decrease. So we'll stop releasing so much bicarbonate in order to compensate for that, trying to keep the system balanced. So, a note about compensation: the respiratory compensation is really quick. That is our fastest way to be able to respond, besides just the chemical buffering, right? The kidney takes a lot longer to be able to do. So any metabolic compensation is a lot slower. And when it comes down to it, compensation is rarely complete. It is often only a partial compensation. So where it's trying to move our pH back to the normal range again, it often isn't quite making it all the way. Or if it does, it's making it to the more extreme levels of the range. So like right around the 7.35 or around the 7.45, instead of getting it back into the middle of the 7.4 range. And patients do not overcompensate. So when you're looking at levels and reading things to try and determine whether we are dealing with respiratory or metabolic acidosis or alkalosis, I want you to keep in mind that overcompensation isn't going to occur. So, really, we're just trying to narrow things down and figure out how we can help our patients best. So, how do we determine what is going on? So, what we would eventually like is to have some type of a blood sample that would actually be able to read what that pH level is. Now, walking through this flow chart is going to be able to help us to determine with levels what are we looking at? Are we looking at acidosis or alkalosis? And that's really looking at what the pH level is. So if it's below the 7.4, it's going to be showing that we are actually in acidosis. If it is above the 7.4, we're going to be looking at us being in alkalosis. Now the next question comes of, is it metabolic or respiratory? So is there some kind of a compensation that's happening? So with acidosis, right? If it is a metabolic acidosis, we're going to know that because our bicarbonate levels are going to be less than 24 milliequivalents per liter. So that's our range when we're looking at our bicarbonate levels. If instead we're acidotic and our levels of partial pressure of carbon dioxide are over 40 millimeters of mercury, that's going to indicate that we are in respiratory acidosis. So it's a way for us to be able to follow it, right? So we say our pH is below 7.4, which means we're acidotic. Now I look at my bicarbonate levels and my levels of CO2 and find out which ones are off. If we are dealing with a high CO2 level, we know that it's respiratory acidosis. And then to find out if we are actually in renal compensation at all, we'll take a look at those bicarbonate levels. And if those bicarbonate levels are greater than 24 milliequivalents per liter, then we're going to know that we actually do have that renal compensation. If we're acidotic and our levels of bicarb are below the 24 milliequivalents per liter, we know that we're in a metabolic acidosis. And then to look to find out if we are compensating through the respiratory system, we can look at our partial pressure of carbon dioxide to see what its level is. And if it's below 40 millimeters of mercury, then we know that we are compensating through our respiratory system for that metabolic acidosis. Now, looking at the other side of the scale, if our pH was higher than the 7.4, we know that we're going to be alkalotic, right? So then we're going to take a look at our bicarbonate levels and our partial pressures of carbon dioxide. And if our bicarbonate levels are greater than 24 milliequivalents per liter, we know that we are in metabolic alkalosis. And to find out if we are compensating through our respiratory system, we can look at the partial pressure of carbon dioxide. And if it's greater than 40 millimeters of mercury, we'll know that we are compensating through the respiratory system. On the other side of the alkalotic scale, we have respiratory, which is indicated if our partial pressures of oxygen are less than 40 millimeters of mercury. If it's less than 40 millimeters of mercury, then we know that we're in respiratory alkalosis. And to find out if we are compensating, we take a look at our levels of bicarbonate to find out if it's less than 24 milliequivalents per liter. And if it is, then we know that we have the renal compensation that is starting to occur. So I want you to keep in mind this graph when we're starting to work through the following examples and case studies. So what I'm going to do is I'll be giving you guys case studies, which will take a look at what our levels are of pH, our levels of our partial pressures of carbon dioxide, and our bicarbonate levels as well. And we're going to follow this by looking at what is our pH? Is it less than or more than 7.4, right? And then we'll be taking a look at what are our different levels of partial pressure of oxygen and bicarbonate levels. So we'll write in our levels here for what we're getting from our case studies. And what we'll be able to tell is by looking at the pH levels, whether it is lower, such as in metabolic and respiratory acidosis, or if it's alkalotic by looking at our pH because it's greater than 7.45. And that could be either respiratory alkalosis or metabolic acidosis. And then when we're looking at this is a way for us to be able to follow the graph across to be able to know which type we are talking about. So with respiratory acidosis, it's indicated by having a lower pH, a higher partial pressure of carbon dioxide, and a higher level of bicarbonate. For respiratory alkalosis, you have a higher pH, but a lower partial pressure of carbon dioxide and a lower bicarbonate level. And again, that level that we're looking at is between 22 to 26 milliequivalents per liter. And then you can follow that along also with our metabolic acidosis with a low pH, a low partial pressure of carbon dioxide, and a low level of bicarbonate. And lastly, we have our metabolic alkalosis, in which we have a higher pH with a higher level of carbon dioxide and a higher level of bicarbonate. So let's take a look at some scenarios and try to determine what we are experiencing with this acid base balancing in these different patients. I'm going to walk us through this first one before I let you on trying to solve them on your own. So, case study number one, a patient is suffering from emphysema and is brought into the emergency room. His arterial blood gases reveal a pH of 7.35, a bicarbonate level of 32 milliequivalents per liter, and a partial pressure of carbon dioxide of 50 millimeters of mercury. So, I have this little graph right here, and what I'm going to do is take all of these data points that I have here from the labs that are coming back and fill them in. So I have a pH of 7.35. My partial pressure of CO2 was 50 millimeters of mercury, and my milliequivalents per liter is 32 for our bicarbonate. Now, what I want to do is I want to look and see, are these higher or lower than the normal ranges that we have for these different variables that we're looking at. So with our pH level, it's on the lower side, but we're not out of range all the way, right? So I'm going to leave that for just right now, and I'm going to look at the ones that actually are out of range, such as our partial pressure of carbon dioxide. And what we'll notice is that it is elevated, right? That 50 millimeters of mercury is above the 35 to 45 typical range. So I'm going to put a little circle around these arrows, which is telling me that that level, 50 millimeters of mercury, is higher than what is expected. Now, I also have my level of bicarbonate also out of the normal range, but it is still in that same direction of going up. So we have a higher level here and a higher level here in these different conditions. So now I'm going to go back to my pH for a moment, and I'm going to say in my pH, we know we're not going to overcompensate, right? So that means that I might make my way all the way up to be back into normal range, but is it on the high end or is it on the low end? Well, we know that it's actually on that lower end. I'm putting this in a lighter blue color just because it's not an actual absolute value of going outside of our range, but it is trending in that particular direction. And we also have that on the graph here. Now, what my job to do is to look at where can I see that all three circles are in the same row, right? I could have a low pH, but I'm not seeing the other data points come through to back that up. Or if I had other data points here that show me that these levels are elevated, when I look at my pH would be elevated, but when I look at my value, that's just not the case. So what this tells me now is that, in fact, this patient is in respiratory acidosis. So, my conclusion that we have is that the patient's in respiratory acidosis and is demonstrating some renal compensation. I know that because I have an elevated level of our bicarbonate, and it's bringing my pH or his pH back to normal values again. If the patient was experiencing metabolic acidosis, which would have been our other option because of the lower pH, we would expect the bicarbonate values to be lower than normal, not accelerated. So this is an example of what I have for our case studies. So we're going to do this a couple more times, and I want you guys to be pausing the videos in between to be able to gauge on what kind of condition our patients are in. If it's respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. So here's our next one. You're treating a patient with a history of vomiting for several days. The patient's blood tests reveal a pH of 7.48, a bicarbonate level of 28 milliequivalents per liter, and a partial pressure of carbon dioxide of 40 millimeters of mercury. So I've got my chart right here. What I want you to do is to work within this chart, do it on a scratch piece of paper, and I want you to fill in the values, circle the arrows that are appropriate to match with what those values are, and try to determine which condition this patient is in. All right, so filling in our values. We had a 7.48 for our pH. Partial pressure of carbon dioxide was 40, and our bicarbonate levels were 28 millimeters, or excuse me, 28 milliequivalents per liter. So when I am filling out and circling these arrows to help me to determine, our pH is elevated. So I'm going to circle those two arrows. When I look at my carbon dioxide levels, man, they're actually right in the middle. So I can't circle anything there as far as elevated or not elevated. Then when I look at my bicarbonate levels, we are looking at an elevated bicarbonate level. So it's here and here. Now, when I look across, I can try to determine, okay, well, this one has this larger or increase of our bicarbonate, but it's not matching with the results that we would need to be seeing with our pH. Here, the pH is elevated, but I'm not seeing what I should be seeing with our bicarbonate if that's the case. But when I look at our metabolic acidosis, it is in fact backed up by having that higher or exaggerated pH levels, that it's more alkalotic, and that it's showing me that I've got the higher level of bicarbonate that's available. So, what would our conclusion be? This patient is experiencing metabolic alkalosis, but there's no apparent respiratory compensation that's happening yet. So right now, it's all happening at that level of the kidney, and or just within the bloodstream, and we're not seeing that compensation come through on the respiratory side yet, which is why we're not seeing any change from normal of our partial pressure of carbon dioxide. Excellent. So we got another case study for you. A 20-year-old woman loses consciousness while shopping. In the emergency room, the physician assesses her comatose state and orders blood and urine tests. The tests reveal the following: both glucose and ketones were present in the urine. That's a very key indicator. Our blood pH was 7.23. Partial pressure of carbon dioxide was 34 millimeters of mercury, and the bicarbonate levels were 15 milliequivalents per liter. So, again, using this chart, fill in what your values are and try to determine which condition this particular patient happens to be in. So when we fill in our values, we have a 7.23 for our pH, 34 millimeters of mercury for CO2, and 15 for our bicarbonate levels. So following along through the arrows, we do have a lower pH. We do have a lower partial pressure of carbon dioxide, and we have a lower level of bicarbonate. So when I look across to determine what condition this might be in, we are looking at metabolic acidosis, right? Because I've got all three of my values are matching in line with that definition of what metabolic acidosis is. So, our diagnosis: patient is experiencing metabolic acidosis with respiratory compensation. Glucose and ketones in the urine are really indicative of diabetes. So, where the normal use of glucose for metabolism is being prevented, we are starting to see this back up and produce more or leave more glucose in the system and produce more ketones. In place of glucose, the fats are being split, and that's what's forming all of that acidicness, lowering the plasma pH. So that's kind of what's happening. To be able to support this diagnosis, we could actually be running some more tests in the urine to be able to find this out. Good. All right, let's move on to case number 4. You're working in the ER after a drive-by shooting. A 23-year-old friend of the victim is also brought back to be checked on. She's breathing rapidly and visibly upset. Her blood tests reveal a pH of 7.45, partial pressure of carbon dioxide of 28 millimeters of mercury, and bicarbonate levels of 20 milliequivalents per liter. So we're going to take a look at our chart. I want you to fill in the values and determine what we're dealing with this patient. All right, so when we fill in our values, we've got a pH of 7.45, partial pressure of carbon dioxide of 28, and a bicarbonate level of 20 milliequivalents per liter. So when I'm trying to determine what we have going on here, and I'm looking for those values that are outside of the normal range, we have this decrease in partial pressure of carbon dioxide, and we have the decrease in the bicarbonate as well. When I'm looking at the pH to see where it's leaning towards that higher end of being alkalotic. So when I look across on this chart and I'm noticing that I have got circles for a low low bicarbonate levels, low carbon dioxide levels, and the higher pH, we're dealing with respiratory alkalosis. So we have respiratory alkalosis occurring and it is partially compensated. Our next one of a case is a 43-year-old male who's experiencing tightness of the chest and difficulty breathing. His blood tests reveal a pH of 7.42, partial pressure of carbon dioxide of 36 millimeters of mercury, and bicarbonate levels of 23 milliequivalents per liter. So go ahead and work on this one and fill in our graph. Maybe this one has you a little bit stumped. Let's take a look at it. So when I fill in their values, we've got the pH is 7.42, partial pressures of carbon dioxide at 36 millimeters of mercury, and 23 for our bicarbonate level. When I'm looking at things to try and find out what's out of range, what I'm noticing is nothing's out of range. So what does this mean? Well, these are actually all normal values. I have no values that are out of range whatsoever. So even though our pH might be going above the 7.4, we're still within normal values of everything else. So at this point, the system is actually working as it's supposed to be. Hopefully that didn't trip you up too much and that you got to learn something, and not always is everything an issue. All right, we've got one more for you. Case study number 6. 28-year-old male has recently returned to the States from a trip to Mexico. During his trip home, he began to feel indigestion and has had severe diarrhea for the past 3 days. His blood tests reveal a pH of 7.19, a partial pressure of carbon dioxide of 34 millimeters of mercury, and bicarbonate levels of 14 milliequivalents per liter. So I want you to fill in your values and I want you to determine what exactly is going on with this patient. So filling in our values, we've got a 7.19 for our pH, 34 millimeters of mercury for our CO2 levels, and 14 for our bicarbonate levels. When we're looking at things that are out of range, they all are out of range. And so we've got a low pH, a low partial pressure of carbon dioxide, and a low bicarbonate level. So looking across the board with low levels all the way across the board, we are looking at metabolic acidosis. So this is metabolic acidosis, probably due to the diarrhea. And we are pretty much uncompensated at this point, simply because our pH levels are still way low, but our partial pressures of carbon dioxide have not dropped too tremendously low. They've only just dropped a very small amount. So really, this is virtually uncompensated as it goes. So that's what I have for you for acid-base balancing and working through those problems. Hopefully that made sense to you. And if you have questions, you can always leave a comment and we'll get back to you.